So good day. Um, the next topic that we'll have is congenital and acquired heart diseases. This is still part of your module 3. So let's start first with congenital heart diseases. Congenital heart surgery is a dynamic and evolving field. The last 20 years have brought about rapid developments in technology, emphasis on a multidisciplinary approach to treatment, and a more thorough understanding of both the anatomy and pathophysiology of congenital heart diseases, leading to the improved care of these challenging patients. The goal in most cases of congenital heart disease is appropriate timing of complete repair, rather than subdividing lesions into cyanotic or non-cyanotic lesions, as was accustomed uh, previous years. A more appropriate classification now divides defects into three categories based on the feasibility of achieving complete repair. So the first one is for defects that have no reasonable palliation and for which repair is the only option, defects for which repair is not possible and palliation is the only option, and defects that can either be repaired or palliated in infancy. So we shall tackle some but not all cases of congenital heart defects, yung mga common lang, most common um, congenital diseases. So for the first category, defects amenable to complete repair, we shall tackle ASD, atrial septal defect, PDA or patent ductus arteriosus, coarctation of the aorta, and total anomalous pulmonary venous connection or pulmonary venous return. This was commonly called TAPVER because R is pulmonary venous return. But Schwartz has now renamed it to total pulmonary venous connection because it is more appropriate. So TAPVC na siya ngayon. So let's begin with ASD. ASD is defined as the discontinuity of the interatrial septum that permits direct mixing of blood between the systemic venous and pulmonary venous circulation. They can be classified into three types: the ostium secundum, which is a deficiency of septum primum, ostium primum, and the sinus venosus. The most prevalent one is ostium secundum, occurring in 80% of cases. So this is the most common. Ostium primum is a partial or transitional AV canal defect. AV is atrioventricular, and sinus venosus occurs in 5 to 10% of all ASDs. ASD results in an increase in pulmonary flow secondary to primarily left-right shunting through the defect. So basically, there is a defect in the development of the septum that divides the left and right atrium. The shunting is left to right because the left ventricular pressure is higher than the RV pressure. So there is an increase in hypertrophy in the left ventricle pressure, and it promotes hypertrophy with a thicker muscle mass, which offers resistance to diastolic filling than does the right ventricle. Thus, the majority of flow occurs from left to right. Those who undergo ASD closure before 10 years have a better likelihood of achieving a normal right ventricle. The physiology of sinus venosus ASDs is similar to the one I discussed earlier, except that these are frequently accompanied by anomalous pulmonary venous drainage, thereby resulting in significant hemodynamic derangements that accelerate the clinical course of these infants. Ostium primum defects, on the other hand, are associated with mitral insufficiency from the cleft mitral valve and can lead to more atrial volume load and increased atrial levels of shunting. So these um, effects may be fatal to the patient, so closure should be done earlier. Auscultation reveals a prominent first heart sound with fixed splitting of the second heart sound. Chest radiograph would show an increased pulmonary vascularity with prominent hilar markings and cardiomegaly. ECG shows right axis deviation with an incomplete bundle branch block. 2D echo provides an understanding of the physiologic derangements created by the defects, and it also enables the clinician to estimate the amount of intracardiac shunting and can also demonstrate the degree of mitral regurgitation in patients with ostium primum defects. Simple secundum ASDs can be repaired via a transcatheter technique and assessment for transcatheter closure with TTE or transthoracic echocardiography assessment is generally indicated prior to consideration of a surgical repair. The most common surgical approach requires a standard cardiopulmonary bypass or CPB technique through a midline sternotomy approach. So basically, an oblique atriotomy is made and the position of the coronary sinus and all um, systemic and pulmonary veins are determined, and then the rim of the defect is completely visualized. So you close the ostium secundum either by primary repair or you insert a patch that is sutured to the rim of the defect. For sinus venosus repair with partial anomalous venous connection, the type of repair is dependent on the location of the anomalous pulmonary vein, so the details of which we won't be discussing. But it is important to take note of a procedure called a Warden procedure. In this operation, the superior vena cava is transected cranial to the uh, connection of the anomalous and the caudal end of the transected cava is oversewn. So the cranial end is then anastomosed to the auricle of the right atrium, and a patch is used to redirect the pulmonary venous blood flow to the left atrium. Surgical outcomes have low complication rates and zero mortalities for patients without pulmonary hypertension. So only for patients with no complications yet. So ASD repair is good. Next we have PDA, patent ductus arteriosus. The ductus arteriosus is derived from the sixth aortic arch and normally extends from the main or the left pulmonary artery to the upper descending thoracic aorta, distal to the left subclavian artery. In infancy, the length may vary from 2 to 8 millimeters with a diameter of 4 to 12 millimeters. At birth, increased pulmonary blood flow decreases prostaglandin products, resulting in a marked decrease in the ductal relaxing substances. So this causes ductal contraction and eventual closure within 10 to 15 hours postnatally, thereby forming the ligamentum arteriosum, which connects the pulmonary artery to the aorta. Delayed closure of the ductus is termed prolonged patency, whereas failure of closure causes persistent patency. This may occur as an isolated lesion, or PDA may be associated with more complex congenital heart defects. So as you can see in the picture, there is a connection. So that's your PDA. This is actually ligated already. So physical examination of the afflicted infant will reveal evidence of a hyperdynamic circulation with a widened pulse pressure and a hyperactive precordium. Auscultation demonstrates um, systolic or a continuous murmur, often termed a machinery murmur. Cyanosis is not present in uncomplicated isolated PDA. The chest radiograph may reveal increased pulmonary vascularity or sometimes cardiomegaly, and the ECG may show left ventricular strain, left atrial enlargement, and possibly RVH or right ventricle hypertrophy. Echocardiogram with color mapping reliably demonstrates the patency of the ductus as well as estimates the shunt size. The presence of a persistent PDA is sufficient indication for closure because of the increased mortality and the risk of endocarditis. So, in premature infants, aggressive intervention with medical management, indomethacin, or ibuprofen to achieve early closure of PDA is beneficial. Term infants, however, are generally unresponsive to pharmacotherapy, so they may undergo catheter-based therapy or percutaneous intervention, or we do the usual open surgery. Preterm newborns and children may do well with a surgical technique, while older patients more than 5 years old and those with smaller ducts less than millimeters do well with coil occlusion. So the catheter-based therapy or the percutaneous intervention is there is a criteria for that. Yung mga bigger um, PDAs, they cannot do coiling. So there is a criteria for that. We won't be discussing it now. Next, we have coarctation of the aorta. So this is defined as the luminal narrowing in the aorta that causes an obstruction to blood flow. So as seen in this picture, this one, oh, there is narrowing of the lumen. The narrowing is most commonly located distal to the left subclavian artery. Physical examination will demonstrate a hyperdynamic cardium with harsh murmur on the left chest and back, and also decreased femoral pulses as compared to the upper extremity pulses. Radiography will show a typical rib notching appearance secondary to the development of extensive collateral circulation in the intercostals and mammary artery as a result of the distal flow obstruction. So treatment for this is usually surgical intervention. The routine management of hemodynamically significant COA or coarctation of aorta has traditionally been surgical. Transcatheter repairs are used with increasing frequency, but they are used in older patients and those with recoarctation following surgical repair. So naoperahan tapos nag-coarctation ulit. Open surgical techniques currently used are resection with end-to-end anastomosis or extended end-to-end anastomosis. Taking care to remove all residual ductal tissue. The first picture here shows a CT angiogram showing a recurrent coarctation repaired by an extra anatomic bypass. The one in the middle shows resection of the segment of coarctation and reconstruction with an extended end-to-end anastomosis. So ito. And lastly, this is an aortogram performed in the cath lab after stenting of the coarctation. So there is a stent para mag-increase ang lumen. Catheter-based intervention has become more widespread for older children and adults, typically balloon dilatation and primary stent implantation. Next, we have TAP VC, previously called TAPVER, total anomalous pulmonary venous connection. This occurs in 1 to 2% of all cardiac malformations and is characterized by abnormal drainage of the pulmonary veins into the right heart, whether through connections into the right atrium or into its tributaries. Accordingly, the only mechanism by which oxygenated blood can return to the left heart is through an ASD, which is almost uniformly present with TAP VC. Darling and colleagues classified TAP VC according to the site or the level of connection of the pulmonary veins to the systemic venous system. For type 1, there is anomalous connection at the supracardiac level, and this is the most common type. So just look at the picture for comparison. Type 2 is at the cardiac level. Yan. Type 3, infracardiac level. This one here below. And type 4 occurs at multiple levels. So, kana. This is also actually an infracardiac type. Low infracardiac level, so type 3. This CT angiogram. Because both pulmonary and systemic venous blood returns to the right atrium in all forms of TAP VC, a right to left intracardiac shunt must be present in order for the afflicted infant to survive. This invariably occurs via a non-restrictive patent foramen ovale. Because of this obligatory mixing, cyanosis is usually present, and its degree depends on the ratio of pulmonary to systemic blood flow. Chest X-ray will show a normal heart size with generalized pulmonary edema. Results for TAP VC in infancy have markedly improved with operative mortality of 5% or less. 2D echo is very useful in establishing the diagnosis and can also assess ventricular septal position as well as estimate the right ventricular pressure and identify the pulmonary venous connection. Treatment is always surgical. So basically, operative correction requires anastomosis of the common pulmonary venous channel to the left atrium, um, obliteration of anomalous venous connection, and eventually closure of the ESD. So we shall not delve into details here, but that's basically the gist of the operation. So now we tackle on the defects requiring palliation. So we only have two: tricuspid atresia and hypoplastic left heart syndrome. Tricuspid atresia occurs in 2 to 3% of patients with congenital heart disease and is characterized by atresia of the tricuspid valve. This results in discontinuity between the right atrium and the right ventricle. The right ventricle is generally hypoplastic, and left heart filling is dependent on an ASD. Trichotresia is the most common form of the single ventricle complex, indicating that there is functionally only one ventricular chamber. Unless there is a VSD, as is found in some cases, pulmonary flow is dependent on the presence of a PDA. As the ductus begins to close shortly after birth, infants become intensely cyanotic. So re-establishing ductal patency with prostaglandins restores pulmonary blood flow and stabilizes patients for surgical intervention. Most infants are cyanotic and hypoxic as a result of decreased pulmonary blood flow and the complete mixing at the atrial level. When pulmonary blood flow is provided through a VSD, there may be a prominent systolic murmur. Tricuspid atresia with pulmonary blood flow from a PDA may present with a soft, continuous murmur of a PDA in conjunction with cyanosis. Chest radiography will show decreased pulmonary vascularity. The ECG is strongly suggestive because uncharacteristic left axis deviation will be present due to the underdevelopment of the right ventricle. 2D echo readily confirms the diagnosis and the anatomic subtype. The treatment for tricuspid atresia in the earlier era of palliation was aimed at correcting the defect in the pulmonary circulation. So that is, patients with too much pulmonary flow received a pulmonary band, and those with insufficient flow received a systemic pulmonary artery shunt. However, long-term mortality was high since the single ventricle was left unprotected from either volume or pressure overload. In 1958, Glenn described the first successful cavopulmonary anastomosis termed the bidirectional Glenn. This is an side right pulmonary artery to superior vena cava anastomosis. Recently, the most um, widespread technique for repair of tricuspid atresia is the Fontan repair. This treatment bypassed the right heart and allowed separation of the pulmonary and systemic circulations. The Fontan repair consists of a classic Glenn anastomosis, ASD closure, and direct connection of the right atrium to the proximal end of the left pulmonary artery using an aortic homograft. The Fontan is usually performed when the child is between 2 to 4 years old and is generally successful if the infant was staged properly with a protected single ventricle and there is adequate pulmonary artery growth. Overall survival is as high as 80% and operative mortality at 2%. Next is HLHS, or the hypoplastic left heart syndrome. HLHS comprises a wide spectrum of cardiac malformations, including hypoplasia or atresia of the aortic and mitral valves, and hypoplasia of the left ventricle and ascending aorta. HLHS has a reported prevalence of 0.2 per 1,000 live births and occurs twice as often in boys as in girls. Left untreated, HLHS is invariably fatal and is responsible for 25% of early cardiac deaths in neonates. As implied by its name, HLHS involves varying degrees of underdevelopment of left-sided structures, such as the pictures shown here. The picture above is an angiogram obtained in a patient with HLHS. Of note is the extremely diminutive ascending aorta, the one with the asterisk. The one below is a 2D echo of a patient with HLHS, and you can see a very small or hypoplastic left ventricle. So, there are four anatomic subtypes: aortic and mitral stenosis, aortic and mitral aortic atresia and mitral stenosis, and aortic stenosis and mitral atresia. Aortic atresia tends to be associated with more severe degrees of hypoplasia of the ascending aorta than does aortic stenosis. HLHS invariably results from a complex interplay of developmental errors in the early stages of cardiogenesis. In HLHS, pulmonary venous blood enters the left atrium, but atrial systole cannot propel blood across the stenotic or the atretic mitral valve into the left ventricle. So, the blood is shunted across the foramen ovale into the right atrium, where it contributes to volume loading of the right ventricle. The end result is pulmonary venous hypertension from outflow obstruction at the level of the left atrium, as well as pulmonary overcirculation and RV failure. Generally, a child with HLHS will present with respiratory distress within the first day of life. Sometimes the patient may also present with mild cyanosis. These infants must be rapidly triaged to a tertiary center and to the echo performed to confirm the diagnosis. Treatment involves a three-stage palliative procedure aimed at number one, bypassing the left ventricle by creating a neo-aorta which arises from the right ventricle, which is called the modified Norwood technique. Number two, creation of a bidirectional cavopulmonary shunt or the hemifontan repair at 3 to 6 months of life. And lastly, the completion of separation of systemic and pulmonary circulation performed between 18 months and 3 years of age, which we term the modified Fontan procedure. So the details, we will not be discussing this. So last uh, category, defects that may be palliated or repaired. So again, there are many defects, but I will only be discussing four. Ebstein's anomaly, transposition of the great arteries or TGA, TOF or tetralogy of Fallot, and the VSD. And we shall just tackle these taphaw lang, not very in-depth because unless you want to be a cardiothoracic surgeon, then you should all be knowing all of this. But at your level, the ones that I'll be discussing is enough. So let's start with Epstein anomaly. This is a rare defect occurring in less than 1% of all CHD patients. The predominant maldevelopment in this lesion is the inferior displacement of the tricuspid valve into the right ventricle. The atrialized right ventricle is usually thin and dilated, and there is commonly an ASD present, which results in a right to left shunt at the atrial level. RV dysfunction occurs in patients with Epstein anomaly because of two basic mechanisms. One, there is inflow obstruction at the level of the atrialized ventricle, which produces ineffective right ventricular filling, and two, contractile dysfunction, inflow obstruction and tricuspid regurgitation, which is exacerbated by progressive annular dilatation. Both produce ineffective RV filling. Contractile dysfunction of the right ventricle is a result of a decrease in the number of myocardial fibers, as well as the discordant contraction of the large atrialized portion. If you look closely at the picture, you can see a displayed tricuspid valve, the one with an asterisk sign, while the arrow points to the atrialized portion of the right ventricle. So this is actually the um, right ventricle. Infants with severe Epstein anomaly usually show cyanosis and acidosis. Some with milder forms may present symptoms of cyanosis during adults or their teenage years. Chest X-ray will show a globular wall-to-wall heart, as in the heart would be expanded throughout the entire um, lung area. ECG would show a RBBB or a right bundle branch block, right axis deviation, and a Wolff-Parkinson-White syndrome. 2D echo confirms the diagnosis, and as with all other congenital diseases, surgery is the definitive treatment. But this is indicated for symptomatic infants as well as older children and adults with arrhythmia, progressive cyanosis, or with the NIHA classification, class NIHA class 3 or class 4, the CHF classification. So, let's proceed with TGA. Complete transposition is characterized by connection of the atria to their appropriate ventricles with inappropriate ventriculo-arterial connections. Thus, the aorta arises anteriorly from the right ventricle, while the pulmonary artery arises posteriorly from the left ventricle. So, baliktad. Van Pra and co-workers introduced the term transposition transposition of the great arteries to describe the defect, but there is also a levotransposition of the great arteries, which describes a form of corrected transposition where there is concomitant atrioventricular discordance. But this is not very common. For purposes of discussion, we will discuss the complete transposition or the dextrotransposition. Okay. So, TGA results in parallel pulmonary and systemic circulations with patient survival dependent on intracardiac mixing of the blood. So after birth, both the ventricles are relatively uh, non-compliant, and so infants initially have higher pulmonary flow due to the decreased downstream resistance. This then causes a left to right shunt and a left atrial enlargement. So the left to right shunt goes through the patent foramen ovale. Infants with TGA and an intact ventricular septum are usually cyanotic at birth with an arterial oxygen pressure between 25 to 40 millimeters mercury. If ductal patency is not maintained, there will be rapid deterioration and death. ECG will reveal RVH and chest X. RVH means right ventricular hypertrophy, yes, and chest X-ray will show an egg-shaped configuration. 2D echo demonstrates ventriculo-arterial discordance and will definitively diagnose the patient. Treatment is mainly surgical. In late 1950s, Senning and Mustar developed the first atrial repair. The Senning operation now consists of rerouting the venous flow at the atrial level by incising and realigning the atrial septum over the pulmonary veins and using the right atrial free wall to create a pulmonary venous baffle. This should be done within 2 weeks at birth to prevent further. So, third third one, Tetralogy of Fallot. The original description of TOF by Louis Fallot, as the name implies, included four abnormalities. So we have a large perimembranous VSD adjacent to a tricuspid valve, an overriding aorta. There is a variable degree of right ventricular outflow tract obstruction or RVOT obstruction, which might include hypoplasia and dysplasia of the pulmonary valve, as well as obstruction at the subvalvular and pulmonary artery level, and a right ventricular hypertrophy. The morphology of TOF is markedly heterogeneous and includes an absent pulmonary valve, AV septal defects, and a pulmonary atresia with major aortopulmonary collaterals. The initial presentation of a child afflicted with TOF depends on the degree of RVOT obstruction. Children with cyanosis at birth usually have severe pulmonary annular hypoplasia with concomitant hypoplasia of the peripheral pulmonary arteries. Most children, however, present mild cyanosis at birth, but then RVH progresses or right ventricular hypertrophy progresses, which then further compromises RVOT. Within 6 to 12 months, cyanosis becomes significant with the occurrence of TET spells, which are periods of extreme hypoxemia. Older patients may often squat, which increases peripheral vascular resistance and leaves the cyanosis. Older patients with TOF may demonstrate clubbing, polycythemia, hemoptysis, and even brain abscess at times. Chest X-ray shows the classical boot-shaped heart, and ECG may reveal right ventricular hypertrophy. Treatment is surgery with operative mortality less than 5% for repair of TOF in infancy without defects. Okay. The details of the procedure will not be discussed here. So, this is the typical X-ray of a patient with a TOF, ha? So, boot shaped kasi it really looks like a boot. It looks like a boot. So, that's your boot shaped heart there. So, lastly, we have VSD. Ventricular septal defect refers to a hole between the left ventricle and the right ventricle. These defects are common, comprising 20 to 30% of all cases of congenital heart disease, and they may occur as an isolated lesion or as part of a more complex malformation. They vary in size from 3 mm to more than 3 centimeters and are classified into four types. The perimembranous VSD or paramembranous, also called conoventricular, is the most common VSD requiring surgical intervention, comprising approximately 80% of cases. The defect in perimembranous VSD involves membranous septum. AV canal or inlet defects occur when part or all of the septum of the atrioventricular canal is absent. Supracanal VSD supracrystal or outlet VSD results from a defect within the conal septum, while muscular VSDs are the most common and may lie in four locations: the anterior, midventricular, posterior, or the apical. So ito ang mga nasa picture. These are surrounded by muscle and can occur anywhere along the trabecular portion of the septum. So, most common is the muscular, I'm sorry about a while ago. So, the most common type of VSD is the muscular VSD. The perimembranous, however, is the most common VSD requiring surgical intervention. Okay, so just to be clear. The size of the VSD determines the initial pathophysiology of the disease. Large VSDs are classified as non-restrictive, and this defect allows free flow of blood from the left ventricle to the right ventricle, elevating RV pressure to the same level as that of systemic pressure. Small, restrictive VSDs offer significant resistance to the passage of blood across the defect, and therefore right ventricular pressure is either normal or only minimally elevated. Physical examination would reveal severe congestive heart failure and frequent respiratory tract infections. Radiography may show cardiomegaly and pulmonary overcirculation, and ECG will reveal left ventricular or biventricular hypertrophy. For the treatment, VSDs may close or narrow spontaneously, and the probability of closure is inversely related to the age at which the defect is observed. Thus, infants at 1 month of age have an 80% incidence of spontaneous closure, whereas a child at 12 months of age has only a 25% chance of closure. So, this has an important impact on operative decision making because a small or a moderate sized VSD may be observed for a period of time in the absence of symptoms. Take note, the patient it should be asymptomatic. Large defects and those in severely symptomatic neonates should be repaired during infancy to relieve the symptoms, and also because irreversible changes in pulmonary vascular resistance may develop during the first year of life. Surgical operation requires a right atrial approach to inspect the anatomy, and then a patch repair is employed. Even in very small infants, closure of VSDs can be safely performed with hospital mortality near 0% in highly special centers. The main risk factor remains the presence of other associated lesions. So that's it for the congenital heart diseases. We now proceed with acquired heart diseases. So most common and the first one that we will be talking about is the coronary artery disease or CAD. Atherosclerotic stenosis are the main primary mechanism of coronary artery disease. The pathophysiologic process is initiated with vascular endothelial injury and is potentiated by inflammatory mechanisms, circulating lipids, toxins, and other vasoactive agents in the blood. Macrophages and platelets are attracted to this area of endothelial dysfunction, thereby initiating a local inflammatory response. During this process, macrophages infiltrate into the intimal layers and accumulate cholesterol-containing low-density lipoproteins. The growth factors secreted promote proliferation of smooth muscle cells within the intima and media of the arteries. Together with the accumulation of the lipid-laden macrophages, the smooth muscle hyperplasia results in an atheroma and subsequent stenosis of the vessel. These atheromas have a fibrous cap that may rupture, thereby exposing the underlying cells and extracellular matrix, which are very prothrombotic. Acute plaque rupture and thrombus formation is thought to be the main pathophysiologic mechanism responsible for acute coronary syndromes. Patients with CAD may have a spectrum of presentations, including angina pectoris, MI, ischemic heart failure, arrhythmias, and sudden death. To evaluate patients with coronary artery disease, coronary angiography is the primary diagnostic tool. Non-invasive diagnostic studies such as stress ECG is frequently used as a screening tool with 50% sensitivity and 90% specificity. So let's go to CABG or coronary artery bypass grafting. So basically the treatment in what do you call this coronary artery disease is either CABG, which is the common conventional, and we now have the percutaneous coronary intervention or PCI. There have been multiple trials comparing the two, and some of them will be discussed here. So excuse me, the New York State study in 2005 is a retrospective review of patients with two vessel or more coronary artery disease. And based on this study, CABG was associated with higher adjusted rates of long-term survival than PCI. The stent or surgery trial in 2008 also showed a survival advantage in the CABG group over PCI. We also have the syntax trial in 2009, and their conclusion was that repeat revascularization and major adverse cardiac or cerebrovascular events at 1 year were lower in cabbage patients, but in terms of the all-cause mortality, there was no significant difference. The ASSERT study in 2012 also showed no difference in adjusted mortality at 1 year, but there is a significantly lower mortality with cabbage than PCI at 4 years. So, what do all these trials say? PCI, percutaneous coronary intervention, has improved over time, and the rates of adverse events have decreased significantly. But CABG maintains improved long-term outcome and remains the standard of care for patients with left main, multi-vessel coronary artery disease, and patients with diabetes. So let's go to selection of the bypass conduit. The most important criterion in conduit selection is the graft patency. The conduit with the highest patency rate, actually it's 98% at 5 years, is the internal thoracic artery. The greater saphenous vein can also be used. Actually, in our setting, this is the one that is most frequently harvested. This is usually done through an open technique, but an endoscopic approach may be used as well. The radial artery is another frequently used conduit, but I have not personally seen this. We just have to make sure before we use the radial artery that the ulnar collateral flow is patent before harvesting this artery. So we shall not delve into the details of the surgery at this moment since it is not important at your level. But the gist of conventional cabbage is that the harvested grafts are anastomosed to the affected coronary arteries in an attempt to bypass the stenosed area. Outcomes have improved for cabbage surgery with mortality rate from 2.4% in 2000 to 1.9% in 2009. Other complication rates, such as stroke, bleeding requiring reoperation, and deep sternal wound infection, have also decreased over time. Now let's proceed with valvular heart diseases, starting off with mitral stenosis. Acquired MS or mitral stenosis is most often caused by rheumatic fever, with approximately 60% of patients with pure MS presenting with a clinical history of rheumatic heart disease. Other conditions causing mitral valve stenosis include left atrial myxoma, prosthetic valve thrombosis, mucopolysaccharidosis, previous chest radiation, and severe annular calcification. As the normal mitral valve area of 4 to 5 square centimeters is reduced by the rheumatic process, blood can flow from the left atrium to the left ventricle only if it is propelled by an ever-increasing pressure gradient. This increased left atrial pressure causes left atrial enlargement and eventually pulmonary hypertension and decreased exercise tolerance. This table is lifted from Schwartz, and this classifies the severity of mitral valve disease in adults. Note that severe MS has a less than 1 square centimeter of valve area, resulting in an enlarged left atrial and ventricular size. Clinical manifestations include the presence of an auscultatory triad best heard at the apex. There is an opening snap followed by a diastolic rumble caused by rapid entry of blood into the left ventricle. When diastole is complete, the mitral valve subsequently closes very rapidly, causing an increased first heart sound. The first clinical signs of mitral stenosis are those associated with pulmonary venous congestion, namely exertional dyspnea, um, what else? Decreased exercise capacity, orthopnea, and um, paroxysmal nocturnal dyspnea. ECG abnormalities may reveal atrial fibrillation, left atrial enlargement, and right axis deviation. On chest X-ray, findings may include enlargement of the left atrium and pulmonary artery, creating a double contour behind the right atrial shadow and obliterating the normal cavity between the aorta and left ventricle. Treatment actually depends on the severity and morphology of the disease of the mitral valve. We may do balloon valvotomy, surgical repair, or replacement. Most commonly in our setting, we usually do surgical replacement or MVR. The procedure is called MVR, mitral valve replacement. So basically, we just remove the entire mitral valve, excise it, and we have a prosthetic valve that is attached to the rim. So that's basically how it goes. Details of which will not be discussed. Now let's go to mitral regurgitation. The most important cause of mitral regurg in the US is myxomatous degenerative disease of the mitral valve, which occurs in 2 to 3% of the population. Other important causes of MR include rheumatic heart disease, infective endocarditis, ischemic heart disease, and dilated cardiomyopathies. The basic pathophysiologic abnormality of mitral regurgitation is the retrograde flow of a portion of the left ventricle stroke volume into the left atrium during systole due to an incompetent mitral valve or a dilated mitral valve annulus. In cases of acute severe mitral regurgitation, patients are often symptomatic and present with pulmonary congestion and reduced forward stroke volume. In chronic MR, patients are usually asymptomatic for long periods due to the compensatory mechanisms of the remodeled left ventricle. As with mitral stenosis, surgery is based on the etiology, morphology, and the severity of mitral regurgitation. In the local setting, patients usually come at a later presentation, so mitral valve replacement is commonly done with an operative mortality between 2 to 6% and a 5-year survival of 65 to 70%. So same procedure as with the previous one, MS, we do mitral valve replacement for mitral regurgitation. Okay, we now have aortic stenosis. Calcific aortic valve disease, also known as senile or degenerative disease, is an age-related disorder characterized by lipid accumulation, proliferative and inflammatory changes, upregulation of ACE activity, angiotensin converting enzyme activity, oxidative stress, and infiltration of macrophages and T lymphocytes. The most common cause of adult AS or aortic stenosis is calcification of a normal trileaflet or a congenital bicuspid aortic valve, particularly in patients more than 70 years of age. Another important cause of AS is rheumatic heart disease, which is particularly common in developing countries. In general, once moderate AS is present, the average rate of progression includes an increase in jet velocity of 0.3 meters per second per year, an increase in mean pressure gradient of 7 millimeters mercury per year, and a decrease in valve area of zero point 0.1 square centimeters per year. The characteristic auscultatory findings of AS include a harsh crescendo systolic murmur at the right, second, or third intercostal space, often with radiation to the carotid arteries. As the disease progresses, aortic valve closure may follow pulmonic valve closure, causing a paradoxical splitting of the second heart sound. Other physical findings associated with AS include an apical impulse, commonly described as a prolonged heave, and the presence of a narrow and sustained peripheral pulse known as pulsus parvus et tardus. The classic symptoms of AS are exertional dyspnea, angina, and syncope. ECG may demonstrate signs of left atrial enlargement in various forms and degrees of atrioventricular or intraventricular block due to the calcific infiltration of the conduction system. Routine chest X-ray usually demonstrates a normal heart size with rounding of the left ventricular border and apex. And a late finding is cardiomegaly, which is a sign of left ventricular failure. Treatment is via balloon valvotomy, which is just a bridge to surgery. This is not the definitive treatment. It is just a bridge to surgery in hemodynamically unstable patients, or this is used as a palliation for patients who are not AVR candidates or aortic valve replacement candidates. Definitive procedure is through AVR for symptomatic patients with severe aortic stenosis. Details again will not be tackled here, but similar with MVR, an aortotomy is done to expose the involved valve, and then we completely excise it, and an appropriate prosthesis is selected and sutured. So that's it. That ends our acquired heart diseases. Again, there are still more discussed in the book, the aortic sufficiency, insufficiency, and others, but I do not deem that very important at your level right now. So we'll just tackle this, review the slides, and then we will do post-test after. Thank you.